Dear students and colleagues, Wilson disease is one of the metabolic diseases and in group of autosomal recessive disorder which characterized by excessive accumulation of copper in organs and particularly in liver and brain. The disease connect with a mutation in the ATP7B gene, which encodes a transporter protein with ATPase activity. And this transporter is involved in incorporating copper into apoceruloplasmin, which is finally should be eliminated in blood. Manifestation of Wilson disease includes many organs and first of all is a liver problem. Liver disease can be present with hepatomegaly, jaundice, pain in right upper part of abdomen. It can be manifest with elevated transaminase level, acute liver injury, with cirrhosis and steatosis. Neurological symptom in Wilson disease very common and can include dystonia, tremor, dysarthria, dysphagia, Parkinson's symptom and symptom of chorea. Psychotic disorder includes behavior change, depression, anxiety, psychosis, sexual disturbances. In eye, of course, a very common Kaiser-Fleischer-Ring and can be another symptom like cataract. Hematological diseases and symptom includes hemolysis, hemolytic anemia, thrombocytopenia, coagulopathy. From kidney, we can see acute renal failure, nephrolithiasis, renal tubular necrosis. Musculoskeletal symptom includes muscle weakness, arthropathy. And it can be other symptom like heart disease, pancreatitis, hypoparathyroidism, and it's not all complication and manifestation in Wilson disease. What we should do for evaluation? We have a diagnostic test. First of all, patient who has elevated liver enzymes LT and AST should be screened for serum ceruloplasmin level. After, we should do 24-hour urinary copper excretion. After, we do MRI of brain, ophthalmological examination, liver biopsy and genetic testing. Because Wilson disease is a genetic mutation, the main confirmation of diagnosis is a genetic test. For laboratory examination patient with Wilson disease, we use level of ceruloplasmin. You see that normal values is 0.2 up to 0.4 gram per liter. In Wilson disease, ceruloplasmin level decrease less than 0.2 gram per liter. But always you should suspect that one lab test can be false negative or false positive. False negative result for ceruloplasmin can be in patient with hepatic inflammation, in pregnancy, in infection, in children. And false positive result can be when patient has low level of ceruloplasmin, can be in situation of malabsorption, malnutrition, in terminal liver disease, liver cirrhosis, in nephropathy with loss of protein, with Wilson disease. Another lab test is non-ceruloplasmin bound copper. In normal, it should be less than 0.3 mg per deciliter. In case of Wilson disease, it should be more than 10 mg per deciliter. But again, in case of Wilson disease, can be false negative result for non-ceruloplasmin bound copper due to overstimulation of ceruloplasmin by immunological assay. And this test can be false positive in another diseases and like cholestatic syndrome, acute liver failure, copper intoxication. Urinary copper excretion for 24 hours is again very informative test. The result in normal should be less than 0.6 micromole per 24 hours. Or less than 40 mg per 24 hours. In case of Wilson disease, urinary copper excretion increase more than 1.6 micromole per 24 hour or higher than 100 mg per 24 hour. Again, in patient with Wilson disease can be false negative result in case of incomplete collection and in children. And false positive result for urinary copper excretion can be in other diseases, not just Wilson disease, and it can be in autoimmune hepatitis, cholestatic syndrome, chronic active liver disease or hepatocellular necrosis in patient with Wilson disease. Wilson disease we use for diagnosing, for informative diagnosing is a liver biopsy result when we see accumulation of copper per gram of liver. And in normal, this result should be less than 50 mg per gram or less than 0.8 millimole per gram of liver. In case of Wilson disease, copper increase, copper accumulate in liver, and this result increase higher than 250 mg per gram or higher than 4 micromole per gram. Again, we can see and negative, false negative result when patient has uneven copper distribution in liver, or false positive result can be in cholestatic syndrome and in idiopathic copper toxicosis disorders. And next examination, ophthalmological Kaiser-Fleischer rinse should be absent in normal and present in patient with Wilson disease, but can be present in patient with primary biliary cholangitis. That's why one symptom, one lab test examination is not enough for confirmation diagnosis of Wilson disease. For diagnosing, we can use any score system. Here present Leipzig score for Wilson disease, where we can calculate points and we can take into account Kaiser-Fleischer rinse, present, absent, neurological symptoms, and grade severe, malto, absent. It's level of ceruloplasmin. It's a Coombs negative hemolytic anemia. It means non-autoimmune hemolytic anemia. Liver copper accumulation, urinary copper excretion, and present mutation of gene for Wilson disease. In totally, we calculate these points, and if patient has a score more than 4, we establish diagnosis of Wilson disease. For treatment this metabolic disorder, we should use any drugs which connect with copper and remove excess accumulated copper. Plus, we prevent reaccumulation copper in patient with Wilson disease. For removing excess accumulated copper, we use penicillamine, trientine, ammonium tetrathiomolybdate. For preventing, we use the same drugs in a more smaller dose. We use zinc injection, and we recommend restrict copper-rich dietary products. Penicillamine, it's a first-line treatment patient with a Wilson disease, and the dose range from 1 up to 4 mg per day. The initial dose require 1.5 mg per day. This dose can be reduced in stage of remission, but treatment should be continued for life, but in more smaller dose. Even if patient has a pregnancy, the treatment Wilson disease should be continued. Abrupt discontinuation of treatment must be avoided because this may precipitate acute liver failure. Trientine is a chelating agent with a similar mechanism of dipenicillamine, and it forms a complex with 4 nitrogen atoms and copper to be excreted to the urine. Zinc acts by blocking the absorption of copper in intestinal tract, and this action both depletes accumulated copper and prevents its accumulation. At this table, you can visualize doses for depenicillamine, trientine, and zinc for initial treatment Wilson disease, for maintenance treatment, for patient who under treatment or non-compliance, and patient with over-treatment or non-compliance. And the first-line treatment again is a depenicillamine. Initial treatment is higher than 500 mg per 24 hours, and maintenance treatment is 200 up to 500 mg per day. Thank you for your attention.